So now Sitaram will talk about probably his experience with producing a pediatric heart valve. And I'm very curious how you solve the problem of growth.
Yes, so I'm going to be revisiting a lot of the similar themes, and I may slip past some of the slides that are redundant. We all understand the unmet need and some of the current options that are available for valve replacement. I need not remind the audience that really there are valve options available for the size greater than 19, and the durability for these valves and their behavior has been covered previously, that perhaps the mechanical valves last longer than the bioprosthetic valves, but they come at a price. I think it has been interesting to look at the only, at least in the United States, FDA-approved mechanical valve for children, the 15-millimeter valve, and several centers that demonstrated that this isn't the panacea. Of course, there are some successful implantations of the mechanical valve in children. We became interested in using the transcatheter bovine jugular vein graft valve for implantation in children to really overcome the issue of fixed diameter valves, that is, the inability to accommodate for growth of the child. And this is really the crux of our observations that has allowed us to think about what the next generation valve might look like for a pediatric heart valve. The problem with the Melody valve is that it's obviously designed for transcatheter use, so it is quite long, and this prevents really ease of use in a pediatric patient. And so in this situation, sometimes we have to actually modify the valve. And as you can see here, we're cutting out a section from the valve in order to prevent left ventricular outflow tract obstruction from the distal portion of the valve. But even under best implantation circumstances, the valve itself lasts about 5 years. And it's mostly because of many of the processes that we've talked about earlier, deterioration of bioprosthetic materials. And here you can see that whether it's implanted into the right ventricular outflow tract or the mitral position, it doesn't last forever. This slide just shows the clinical experience with implantation of mitral valves in children, and you can see that all of the curves drop off quite steeply, and that's obviously important to note. So what are the modes of failure, and what do we learn from this? Because obviously failure is the foundation of eventual success. And so we've covered some of these previously with regard to thrombosis, acute thrombosis on the surface of a material. But I would also point out that thrombosis can occur within the fibers of a material and perhaps lead to disadvantageous remodeling of the leaflet and calcification. There can be pannus ingrowth from adjacent structures and leaflet stiffening related to the immune-mediated responses that we've talked about earlier. The cyclic stress and strain can lead to failure of material that are implanted. And so the question is, can we adequately address all of these concerns with the valve design? Several observations. Most of the valves that are currently implanted, whether it be bioprosthetic or mechanical valves, have quite a short profile, which is useful for implantation and prevents obstruction. But it also leaves ease of ingrowth of pannus material. So this is why I think we frequently see failure of these valves, whether it's mechanical or biological valves. You can see the pannus ingrowth on this top section here on a mechanical valve. What was interesting in the Melody experience in the mitral position is that the leaflet material rarely had pannus ingrowth. And in fact, when we explanted the valves, we could frequently find that the pannus ingrowth was along the exterior surface of the stent for a distance of approximately 9 to 12 millimeters, but it never made a 180-degree turn around the top of the stent into the internal apparatus of the device. So one thing that we started to think about in terms of valve design is creating a valve within a tube to prevent pannus ingrowth from affecting the leaflet of the material. So instead of an open stent design, really a closed stent design was one of the early thoughts that we had. The other important aspect is that the edges of the valve, both the proximal and the distal edge of the valve, should not be contiguous with tissue material. That is, it shouldn't be sitting flush with a material that can ultimately lead to pannus ingrowth on either ends of the valve. Next, we wanted to think about, well, growth adaptation. How do you allow for a valve to grow? And one of the interesting findings from both the Melody valve experience as well as other simulations that I'll show in a second is that a venous valve functions at various diameters. And we saw a little bit of this in the earlier talks today, that up to a certain extent, you can allow a venous valve to expand and still have it be functional. And this is obviously Mother Nature has figured this out because we all have venous distension at various rates, and we want the valve to work at those various diameters. And one of the observations has been that a venous valve has quite tall commissural posts. And this really allows it to function over a range of sizes. So whether it be a 3-leaflet venous valve, as in the setting of the Melody valve, or a 2-leaflet bicuspid valve, what we found is that with the valve simulation, that if you grow the root, you can get functionality of the valve over a range of diameters. But what seemed much more reliable was a bicuspid leaflet design. And earlier, Dr. Schmidt referred to the inability of a bicuspid leaflet to open all the way, and so it can thereby restrict the opening. So what we found in a venous valve is that with a very large free edge length, you can get quite a bit of opening of the valve to almost the entire diameter, but also it allows the valve to expand over time so that with growth of the valve, there isn't impingement upon functionality. And in fact, in our simulations, we found that you could get much more growth of a venous valve with the bicuspid design as compared to a 3-leaflet design. So based upon this, we decided to mimic or use the venous valve design, and particularly a bicuspid leaflet. Next, we had to think about, well, what type of external housing materials do you use? And currently, a stent is really the standard. It's used very commonly. We know we can expand it. But there are other materials that can expand, and this is a PTFE that is created with special nodes so that it is expandable under the right amount of distension. So you can use a number of materials to create an expandable valve. The next issue that we had to address was the stress-strain issues and leaflet fractures. And we knew from the Melody valve experience, again, this is a Melody valve that was explanted, and we found a nice big hole in the center of the belly of the leaflet. And what was becoming obvious to us is that as you expand a valve design, the area that is the most likely to tear is the area that is the straightest, that is the area that is along the belly of the leaflet, because that part expands, but the leaflet material is of a fixed diameter. If you can focus the expansion within the commissures, then you have more leeway, because in that section the valve leaflet isn't being stretched to the same degree. And so in creating a valve design, we wanted to focus valve expansion away from the belly of the leaflet and more into the commissures, because we think that that's where the growth potential really is. In terms of thinking about the valve leaflet material, and I didn't put the Zwiggy box here, but this is kind of the Zwiggy box, if you will, of all of the considerations that we had. What types of materials to use and in what configuration it was of great discussion. Here you can see our initial experiments with PTFE implantation as a valve leaflet. And one of the first concerns was the development of thrombus within a foreign material. But what was interesting is that the location of thrombus, it tends to be in areas that are with less turbulent flow, and typically at the base of the leaflet. So here you can see a valve design, and this is the external housing, and this is a PTFE leaflet. And right at the base of that leaflet, down at the corner, you can see a small clot that has formed. And so, again, when we think about sinuses of Valsalva and trying to recreate an area that is not stagnant flow to prevent thrombus formation, there was another consideration of actually creating a small perforation in the, a controlled perforation in the belly of the leaflet in that particular region where clots frequently form, to basically create, to prevent stagnation of flow. So as we started to put together all of these various designs, there are a couple of valve technologies that I'll describe. This one was directed by Dr. Pedro Del Nido and Sophie Hofferberth, who is one of the fellows in the lab, and then basically left clinical surgery to pursue this, and is currently guiding the clinical trials for this valve. So it's a PTFE-based material with an external housing, using a bileaflet design, mimicking a venous valve. And it is implanted at a small diameter, and let's say we have an initial design that is 12 to 13 millimeters in diameter. It can go up to 22 millimeters in diameter. So those are the parameters that we picked, and you could pick the materials in such a way that you can create a range that is of interest to you. But the more expandable the valve is, the taller the valve needs to be. And so in these initial experiments in growing lambs, the valve was implanted at a small size and then balloon dilated in the cath lab at various time points. And in growing lambs, they actually grow quite quickly, so you can see it's measured in days rather than years to get to the point that they're actually at the size that a human would get to in years, and found that with this design that we had adequate valve function. Again, it's a short time frame, short amount of exposure time, but demonstrated the concept that you can have an expandable valve that is based upon a venous valve design. This next valve is one that I'm currently working on and is in animal studies, and uses some of the very similar concepts. So we have a closed cells, we have a stent that is housed within with a wall that prevents pannus ingrowth, uses a bicuspid venous valve design. And in this situation, we're actually utilizing a growing stent, so a stent that exerts radial force externally onto the annulus, so that as as the valve annulus grows, the valve can grow with it up to the extent that we want it to. So using novel sort of cell design, we can create a valve that expands with the right amount of radial force, such that it encourages growth, but not so much that it actually destroys the tissue. We decided to use actually a femoral venous valve, so allogeneic, human-derived femoral venous valve for our initial design. These are available off the shelf, and so we assembled this on this self-expanding stent, and are currently in the animal trial phases with this. So I'm going to stop my talk here just because I want to leave time for discussion, but to really say that this isn't the end, and there will be multiple generations. But what I want to emphasize, and I know Christophe had really emphasized this earlier, is that we have to take individual observations and then try to put them together in a way that allows us to come up with a rational valve design. And I think we've heard of a lot of important components here. I think the one component that none of these designs really takes into consideration that really struck me with Dr. Vogel's talk is about the endothelium and the protection of all of these materials by endothelium. Just kind of getting back to our discussion earlier about allogeneic responses. We noticed that in heart transplant patients, valve dysfunction is rarely an issue, despite the fact that there might be a massive immune response, right? And what's the difference there? Well, I wonder if it's because that it's regulated by the presence of an endothelium. And one of the things that I think you mentioned in your talk, and I think will become very important, is understanding these interactions in a very meaningful manner. And I'd love to hear more ideas. I think we've really gotten to the point where we understand some very basic concepts, but we certainly have a long way to go. Thank you very much.